This is a 63-year-old woman who had an anterior myocardial infarction. You can see she has a dyskinetic aneurysmal LV apex, but what may be harder to appreciate is this increased signal right here, which is due to an apical ventricular septal defect. It's easier to see here on these gradient echo images because the echo time is longer. You can see this dark jet of blood in systole at the site of the VSD. You can also see in this image right here a jet of tricuspid regurg. Now if we want to quantify the flow, we can just go to the flow module here, and these were automatically done with pre-processing. You can see the image quality is not so great, but that the computer nicely identified the pulmonary artery, and we made 3 separate measurements that were reasonably consistent. It also identified the aorta automatically, and when we look at the QPQS, you can see that the aortic flow is 42 milliliters per beat on average, and the pulmonary artery flow is 96 milliliters per beat on average. You can also see that there's no reversal of flow in diastole, showing there's no significant aortic regurgitation or pulmonic regurgitation. Now if we go back to the function and we look at the short axis images, here are a stack of short axis images. Again, these were all done with pre-processing with no editing of the contours, and you can see the image quality, especially on some of these slices, is not so great. The contours are pretty good given the quality of the images, and you can see that we got an LV stroke volume in this case of 95 cc's per beat and an RV stroke volume of 65 milliliters per beat. Now the question is, do these numbers make sense, and how do we interpret them? So in a normal patient, the LV stroke volume equals the aortic flow, and the RV stroke volume equals the pulmonic flow, and the total combined ventricular output equals the total combined flow. In a patient with a restrictive VSD, however, the LV stroke volume is elevated because blood is now, in addition, going through the septum into the right ventricle, and so therefore the LV stroke volume is elevated, and so is the pulmonic artery flow. But the RV stroke volume is unchanged. The RV stroke volume will be of the same magnitude as the aortic flow. This seems counterintuitive, but let's see if that's true in this case. So here in this patient we had an LV stroke volume of 95 milliliters, and sure enough we had a pulmonic flow of 96 milliliters. Those two numbers are essentially the same. Now when we look at the RV stroke volume, it was 65 cc's. That actually exceeds the pulmonic artery flow by 42 milliliters. And why is that? Well, if we look, the total combined ventricular output is exceeding the total combined flow because some of the ventricular output is going back from the right ventricle into the right atrium by means of tricuspid regurgitation. And we can calculate that as simply the difference between the RV stroke volume and the aortic flow, which in this case is 23 milliliters. So to conclude, a simple restrictive VSD results in the LV stroke volume equaling the pulmonary artery flow and the RV stroke volume equaling the aortic flow. If there is concurrent valvular regurgitation, the LV stroke volume can exceed QP by the sum of the aortic and mitral regurgitation, and the RV stroke volume can exceed the QS by the sum of the pulmonic and tricuspid regurgitation. Thank you very much.